Welcome to Breakout Session B, the genetics of retinal eye disease. How did I get this? Why bother with genetic testing? And why do my genes need therapy? So, good morning. I'm Ann Morrison, and I'm the Director of Philanthropy with the Foundation Fighting Blindness. And before we welcome Melanie Napier to the podium, I'd like to introduce a new education video by the Foundation Fighting Blindness, and it's called Understanding Gene Therapy. This is a quick video, and it's an excellent introduction to gene therapy, and it's also available on our website. So say you watch and go, oh, I know somebody who needs to see this. You can find it on our website, and it has been made possible thanks to the generous donation of Steve Beatty and Fight for Sight in memory of his late wife, Donna Beatty. So I hope that you find it very informative. After the video, I'll introduce our speaker, and we'll get on with our session.
For most of us, vision comes naturally. We don't think about the process behind it, but vision is a process. Light comes through the pupil, it is focused by your lens, and it is turned into signals your brain can understand by an amazing bit of tissue at the back of the eye called the retina. The retina is the busiest part of the body. Each cell is a light processing factory. The factories gather light and convert it into electrical messages that can be understood by the brain. The operating instructions for these factories are called genes. People with inherited retinal diseases have an error in these operating instructions. This error, called a mutation, may mean that some crucial part of the process just doesn't happen, resulting in vision loss. One missing piece can shut down the assembly line and eventually the entire factory. The goal of gene replacement therapy is to provide new instructions to keep the factory working. So how do we get new instructions into the factory? The biological world already has specialists in industrial espionage called viruses. Viruses infect cells by sneaking into the factory. They take over the factory by giving the cell's machinery new instructions. Scientists use these stealth skills to design new therapies for vision loss. The scientists remove most of the virus's own genes, then they put new instructions into the shell of the virus. Scientists then inject these biological secret agents into the retina. Gene therapy can be adapted to treat many different blinding mutations. It cannot repair a cell factory that has been destroyed. However, the first human trials have shown that gene therapy can repair the assembly line and improve vision. Scientists funded by the Foundation Fighting Blindness are working on gene therapies and other types of therapy to protect vision cells and restore sight. To learn more about this and other sight-saving research, visit ffb.ca or call 1-800-461-3331. Donate today. You'll see results.
I'd now like to introduce our next speaker, Melanie Napier, to help us understand the genetics of retinal eye disease even better. Melanie Napier is a genetic counselor at London Health Science Centre. She has a special interest in genetic education and has completed a research project entitled Gene Therapy, Perspectives from Young Adults with Leber's Congenital Amaurosis. There'll be time for your questions, so please hold your questions to the end of her talk. And during question period, please put up your hand and a volunteer will bring over a microphone to you, because it's better when everybody can hear the question. So, and please ensure you use the microphone, and if not, it makes it difficult for our speaker to hear and everybody else. So please welcome Melanie Napier.
Thanks so much for the introduction, Ann. Again, I'm Melanie, and I work as a genetic counselor at London Health Sciences Centre. So I thought one of the first things I should tell you about is what is a genetic counselor, for those of you who haven't met with one who do have a genetic eye disease. Because a genetic counselor, it's kind of an important thing for me to explain to you before I start talking to you about genes. So I am an expert in genetics. I'm a healthcare professional who works with individuals who have genetic diseases or have a family history of genetic disease. So what we do is we work with individuals to explain, what is a gene and why is it important to know what genes are? What does that genetic eye disease mean for the person? What does it mean for their family members? What does it mean if you go on to have children? Will you have a child with the same disease? Will you have more siblings with that disease? So we talk about the risk to pass on the disease and what does it mean for your partner and things like that. We also help people to understand reasons for management and different research projects that may or may not be available for individuals. So especially we know in the low vision area, there's lots of different research and there's lots of ways that people can get involved. So we often help link people up to first support organizations like the Foundation Fighting Blindness. And if we're aware of any research trials that individuals may qualify for, we can help put you in touch with the researchers if that's possible as well. So it's a very all-encompassing role. And what I'm going to talk to you about today, I'm going to spend the first bit of time kind of reviewing a little bit of what the video covered. I'm going to talk about genes. What are genes? And really break it down so that we're all understanding, because I know there's some of us in the room who've probably studied biology after high school, and for some people it's probably been a very long time since anyone's taken any high school biology classes. So I'm going to make sure I cover all of that information for everyone so we're all on the same page. And then I'll get into discussion of different ways that eye diseases can be inherited, because there's a number of different ways, and the way that it's inherited means different things for different families. So I think it's really important that we go through all the different ways it can be inherited, and then we'll talk a little bit more about why should you bother with genetic testing, coming to see a genetic counselor, and what doors would that open for you in terms of things like gene therapy, which the video talked about a little bit. And we'll get into a little more detail about what gene therapy actually is. And then I'll open it up for questions, keeping in mind that I know there's probably a number of different eye diseases, so it'll be hard to speak to specifics in my talk. So if you have questions about your specific condition, we can maybe address it in the question period or even after. And just so you know, I have a colleague here as well, and his name is Nolan, and he'll come up for the question period as well, so we can field some questions together, and we're both staying for lunch as well. So should anyone have any questions, you can always find us at that point as well if you have further questions. All right. So I'm going to start with what is a gene. So to get into that, we have to think about our bodies. And our bodies are made up of millions of cells. And we know that most of our cells contain genetic information in them. And when I talk about genetic information, I'm talking about our DNA. And DNA really is like the instruction manual for the body. It tells us everything about ourselves. How tall are you going to be? What color is your hair going to be? It also tells us how our eyes are going to work. And so when we think about DNA, I said it's the manual to the body. A gene is a very small segment of that DNA that gives the body a very specific instruction. It tells the body how to do one very specific thing. And when we think about genes for our eyes, we know that alone, just for genes that cause retinal eye disease, there's hundreds of them. There's over 150, probably more than 200, that direct our eyes and tell them exactly how to work. So you have to think that every instruction that's telling the eye how to work is very specific. Those instructions are very precise. Just like any other instruction, it's so important that our genetic instructions are being made properly and that the body's getting the correct instruction. So, for example, for those of you who came out of town to Vision Quest today, and someone said, okay, to get to Vision Quest, you have to take the 401, and you have to get off at the Wellington exit, and then you have to go to the 4-Point Sheridan, it'll be on your right side. It was probably pretty easy for you to find this place. But if someone said to you, go to Vision Quest, it's in London, it's not really helpful for you, especially if you've never been to London before. If you don't have access to the internet, you can't Google things. It's really not a helpful instruction. And the same with the genes for our eyes. If that instruction doesn't tell the eye how to work properly, the eye really doesn't know what to do. And like I said, there's hundreds of different instructions that direct it how to work. But if that one instruction isn't working properly, the eye can't do its job the way it's supposed to. And therefore, it causes all of the different symptoms of the different eye diseases, depending on which gene has a problem with it. So in genetics, we call a spelling mistake in the genetic instruction a mutation. So when you hear the word mutation in a gene, it's exactly the same thing as a spelling mistake or a typo in the instruction. Okay? So on top of that, when we talk about genes for eye diseases, everyone in this room has exactly the same genes. We have all of the same genes for our eyes. All over 200 of them, we all have those same genes. The thing is that someone with a genetic eye disease, they have a mutation in their gene. That's in a certain gene that's specific to their eye disease. Okay? Now, when it comes to those genes as well, we know that most of those genes come in pairs. And this is where we start to talk about inheritance. We know that we get one copy of most of our genes from our mother in the egg, and we get one copy from our father in the sperm. So most things come in pairs. There are exceptions to every rule, of course, and I'm going to explain it briefly because it is important when I talk about the way that some conditions are inherited. The exception is we know that our DNA is compressed into little packages called chromosomes. The differences between men and women are that women have 2 X chromosomes, and it's just the way they're named. There's nothing particular about an X. And then there's men, and they have 1 X and 1 Y. So that's really the difference between men and women. Women have 2 X's, so they have double copies of some genes, and men have 1 X and 1 Y, so they only have 1 copy of some of their information. And that'll be important a little bit later when I talk about certain types of inheritance patterns. Okay? So I'll get into now, we know a little bit about genes, we know how they work, we know that most of them come in pairs. So now we'll talk about, well, how do you get these mutations? How are they passed on in your family? Because some of you are probably sitting here saying, yes, I have other family members who have the same eye disease that I do. Some of you may say, I'm the first one in my family, I'm the only one, and I don't really know how that happened. So this is a way to explain a little bit on how those different patterns happen in different families. So the first one I'm going to talk about is what we call autosomal dominant inheritance. And I'm going to give examples for each of them. So autosomal dominant inheritance, for example, retinitis pigmentosa. It can be inherited in many different ways. So if you're listening and you think this doesn't fit my type of RP, not to fear, there's other ways it can be inherited, okay? So for autosomal dominant inheritance, so we have to think that everyone has 2 copies of those genes. If you have a mutation in a specific gene that's inherited in an autosomal dominant manner, that means that one of those genes in your pair has a mutation. So even though you have 1 copy that's working fine, it doesn't really matter because having that 1 copy that has the mutation is what causes the disease in yourself. Okay? When you think about this, if you have 1 copy with a mutation and 1 copy that doesn't, and you've inherited a copy from each of your parents, if your eye disease is inherited in this way, you would have received 1 copy with a mutation from one of your parents, either your mom or your dad. And that means the copy without the mutation came from the other parent. So if you think about your parents, it means that most likely one of your parents also has the same eye disease that you have. Okay? And so when we think about this pattern, we often see it running from generation to generation to generation. We see a parent, and then a person has it, and they may have a child with a condition. But it doesn't mean that just because you have a condition that's inherited in this way that you're necessarily going to have a child with the same condition that you have. And this is, again, because you have 2 copies of that gene. One is working properly, and one has the mutation. So every time you yourself go on to have children, you can either pass on the copy that's working just fine and have a child without the eye condition that you have, or you're going to pass on the copy with the mutation and have a child that has the same disease that you have. So it becomes a 50-50 chance in autosomal dominant inheritance that you are going to have a child with the same condition that you have, and when you think back, you likely have a parent that has the same eye disease that you have. Okay? So that's the dominant inheritance pattern, where only 1 copy has a mutation to have the disease. The next common inheritance pattern is called autosomal recessive inheritance. In recessive inheritance, these are conditions, again, RP falls into this category, Leber's congenital amaurosis, Usher's, Stargardt's, and many more. So those are just some other examples of conditions that are inherited in this manner. For autosomal recessive inheritance, we think about a person's gene pair. In dominant, they have one mutation in one gene of the pair. In recessive disease, someone has a mutation on both copies of their gene pair. So we would think back, if that person inherited those genes from each of their parents, both of their parents would carry a mutation as well on one copy of the parent's gene pair. So this is a little different than autosomal dominant, where if someone has one mutation, then they have the disease. Parents of an individual who have an eye disease inherited in this manner may have one mutation, but they usually don't have any symptoms of the disease themselves. And that's where we call these individuals carriers. You may have heard someone is a carrier of the eye disease because they have a child with the condition. So in this type of condition, that gene, having one mutation, is okay because having 50% working is enough for this type of disorder. So autosomal dominant, having one working, isn't good enough. But in recessive, it's fine. So someone who has one mutation will have healthy eyes in terms of that genetic disease and won't have any signs or symptoms. And they often have absolutely no idea that they're a carrier of this disease until they happen to meet someone and have a child with them who has that, who ends up getting a diagnosis of that condition. And it's not until after the child is diagnosed that they learn that they themselves are a carrier and that their partner is a carrier of this condition. And oftentimes, when these eye diseases are being diagnosed, many times a child isn't diagnosed until they're a little bit older, so there may be a chance that other children in the family are diagnosed. So in this inheritance pattern, it doesn't necessarily go from parent to child and all the way down. We often see if someone's going to be affected with the condition, it's going to be a sibling of someone who already has the disease. Okay? So when we think about this inheritance pattern, when two parents are carriers of a genetic eye disease, we know that every time they have children, they won't always have a child with the genetic eye disease. There are other possibilities that are available. Okay? And that's because we have no control over which genetic information we pass on to our children. It's a complete random guess. It's just like having a boy or a girl. Nobody really gets a choice in what they're going to have. You just find out what you're having. And it's the same thing with our genetics, with what genes we pass on for eye diseases, when we're carriers of things that we don't know about. So if we think about two parents who are carriers, and again, that's one copy with a mutation and one copy without for both parents. When they go on to have children, they have to pass on at least one copy of that gene. So both parents, for example, could pass on their copy with the mutation. And in that case, they would have a child with the eye disease. Both parents could pass on the copy that doesn't have the mutation. And in that scenario, they would have a child that is not a carrier and is not affected. Okay? And then parent A, let's say the mom, could pass on her mutation, and the dad passes on his working copy, and that would be a carrier child just like themselves. Or the other way around, the mother passes on her copy without the mutation, and the father passes on his mutation. And that, again, would result in a child that is a carrier of that eye disease, but does not have the disease themselves. So it's a lot of talking. So to summarize that bit of information, what that means is there are 4 options every time a couple who are both carriers have children together. They could have a 1 in 4 chance of having a child with the disease, a 1 in 4 chance of having a child that does not have the disease and is not a carrier, or a 2 in 4 chance that they would have a child that's a carrier. Okay? So that's how, in these conditions, sometimes there's only one person in the entire family, and they come to genetics and say, but there's no family history. Nobody else has this. How can it be genetic? Disorders that are inherited in this recessive manner are sneaky. So they really kind of trickle in, and nobody knows anything about it, and suddenly someone has the diagnosis, and it really does take a family by shock. Everyone's really shocked when they get this diagnosis. How can it be genetic? Because it really is a hidden, sneaky disease that really can be passed on. People are carriers for generations and generations, but until you find out that you have a child with the disease, you don't know you're a carrier. Okay? And the thing is, we're all carriers of something. We just don't know it. We're all carriers of probably at least 8 to 10 different genetic conditions, and we will never know about it until we happen to have a child that is diagnosed with a genetic disease. So it's something that people often don't know about. It is very shocking. It's very different than that dominant pattern I spoke about, where people know there is a family history of something. Okay? And the last inheritance pattern is what we call X-linked. So this is where I talked about the difference between males and females, where females have 2 X chromosomes and men have an X and a Y. Okay? So for X-linked conditions, again, RP falls into this category, so it falls into every category. So that's just a sneaky one as well. And then we also have choroideremia, retinoschisis, congenital stationary night blindness. Those are conditions that also fall into this category of X-linked. In this condition, you can imagine if you're a man and you have only one X chromosome, and that gene for that disease is on your X chromosome, if you have a mutation in that X chromosome, then you don't have any backup working copies. The only copy you have isn't working properly, and therefore, if you're a man who has a mutation in a gene for eye diseases on your X chromosome, it's a mouthful, then you are going to have that eye disease. Okay? If you're a woman who has a mutation on one copy of her X chromosome, you have a backup copy that kind of does the job, and it kind of hides like that carrier state in recessive inheritance. You have a backup copy that's doing the job and can most of the time hide that disease for you. Now, it's not to say women are completely free and clear in this type of inheritance pattern, because we know if a son is diagnosed, we can look into a woman's eyes and say, you know, if we look really, really closely, you have some signs of that genetic eye disease, but it's not nearly as severe as what we see in your child. So it's often not noticeable. A woman can go her whole life and never notice any problems with her eyes, but if we take a close look, sometimes she can have mild changes to her eyes, and at the same time, some women, maybe their backup copy isn't doing as good a job, and they can have slight symptoms of the disease, but it's never nearly as severe as in a man. Okay? So what does this mean for someone with an X-linked condition who's thinking of having children, and what does it mean when we look at the family history? If we look at a man who has a genetic eye disease that's inherited in this way, every time he goes on to have children, he can either pass on his Y chromosome and have a son, or pass on his X chromosome that has a mutation and have a daughter. Because we know that his partner will always pass on an X chromosome. And because of the rarity of these diseases, we assume his partner is not a carrier on her X chromosome of that same eye disease. So if he passes on a Y and his partner will pass on one of her 2 X's, it doesn't matter which one, he will have a son that does not have the disease that he has, and his son won't have any signs or symptoms in his whole life. He can't inherit that gene. If he passes on his X chromosome, he will have a daughter, and it doesn't matter, again, what his partner passes on, because she will always pass on an X chromosome. So that means his daughters will all be carriers of the disease. They won't have severe signs or symptoms. They won't be nearly as affected as their father, but they themselves can have children. They can have sons with the disease as well. So if we think about a woman who's a carrier of a disease on her X chromosome, when she has children, she can either pass on her copy of the gene that is the working copy on the X, and if she passes on that copy, it doesn't matter. If her partner passes on an X, they will have a daughter who's not a carrier, and if he passes on his Y, they will have a son who is not affected with the disease. If she passes on her X chromosome that has the mutation, and her partner passes on his X, they will have a daughter that's a carrier just like herself. Or if he passes on his Y chromosome, then they will have a son who is affected with the disease. So in that case, to summarize all of that talking as well, if there's a woman who's a carrier of an X-linked condition, Every time she has children, there is one of 4 options. She will have a son who is not affected, a son that's affected, a daughter who's not affected and not a carrier, or a daughter who's not affected but is a carrier. So X-linked conditions can be, again, similar to recessive. It can kind of be a sneaky disease as well, like the recessive, in that you can have women who are carriers for generations and not know it, and then suddenly there's a little boy who's diagnosed with a genetic disease because of the way that it's passed on as well. Okay? So it's a lot of talking about genes and how they're inherited there. So if I'm not clear, because it's sometimes hard to do it without pictures, I can certainly go over it and explain something if you have more questions about your specific eye disease or a certain inheritance pattern that I wasn't clear about. So the next thing I'm going to talk about is why bother with genetic testing? Why would you want to come see a genetic counselor like myself? So one of the reasons is you can get a one-on-one session where we can go over this in more detail, very specific to your eye disease, because again, it's a lot of information to try to cover for a large group of people. So we could go over the information specifically about your eye disease, talk about how it's inherited in your family, take a family history and really kind of explain it on a more personal level for you. That's one of the benefits, is just that understanding. We can sit down in an appointment, there's no physical exam, I'm not looking into anyone's eyes, and we can just talk about that eye disease and give you the time to ask your questions, and we can answer them in that time. We also talk about genetic testing, which is an option for everyone. Whether you come to the appointment and you want the testing or you come and you don't, that's completely up to you. But what we do is talk about the options that are available for you based on the eye disease that you have. So we'll talk about, whichever eye disease it is, which genes are responsible, how it can be inherited if you don't know, if there's no family history. We can talk about how it's inherited. We can talk about what does genetic testing entail. Because genetic testing, unfortunately, I know everyone is always looking for a quick answer, a quick fix. Why do I have this? How did it happen? There's lots of genes, like I mentioned, that are involved with these eye diseases. For some eye diseases, we do know there's one gene that causes the majority of cases of this disease. For like Stargardt disease, for example, we know that there is one gene that's responsible for the majority of cases of individuals with Stargardt. But if we're talking about retinitis pigmentosa, you may have heard that it falls into every disease category. There's more than 5, there's more than 10, there's more than 15 genes involved in retinitis pigmentosa. So the type of genetic testing is going to be very different for someone with RP than someone who has Stargardt's disease. And the genetic testing may not be 100% perfect. It doesn't mean that if you come in and we do this testing on you, we're going to definitively say, aha, we found the exact mutation, that exact spelling mistake in that gene, and we can tell you everything you need to know about your disease now based on this exact mutation we find. Unfortunately, it's not that perfect. Science still has a lot to do. We still have a lot to learn. But what we've learned in the last few years is astronomical. We're learning more and more every day because of all the research that's going on with these eye diseases. But we can certainly come into this appointment and tell you what are the genes that are most likely to be causing your genetic eye disease. We can talk about the type of testing that's available and how likely the testing is to be to find your specific genetic mutation. And it does depend on which disease you have. The numbers are very different depending on what disease you have. But for some families, it's really important to go through that and find out what is that exact mutation. Why is that? Well, for some people, if we find out what the mutation is, we can tell you what the inheritance pattern is going to be in your family if there's no known family history, which may be important to someone who's thinking of planning a family or having kids of their own, or has extended family members who want to know, are they at risk to have a child with this disease? So it might be important for you to know which gene is causing your eye disease, because it's not only important for you, but it has important implications for your family members. Because a cousin, even though they don't have the eye disease, they actually have a chance to be a carrier, because one of your parents could be, and it could be their aunt or uncle, their parent's sibling, who's also a carrier. So it does have implications. Your genetic eye disease does have implications for family members as well. Also, on a more selfish note, sometimes genetic testing can give you information about which gene is in your eye disease, which may in turn make you eligible in the future for some types of clinical trials that are available. We know that there are hundreds of different genes involved, and a lot of these different clinical trials really are very specific for certain eye diseases and for certain mutations within those eye diseases. The reason for that is all of those genetic instructions tell the eye how to work in a very different way. All of those instructions are slightly different. To fix the problem, we actually have to go to that very specific instruction or that specific part of that long line of instructions and fix the right thing. So that's why we need to know what someone's mutation is to enroll them in the proper therapies so that we can make sure that their eyes are actually getting benefit from those therapies that we're providing or offering to them. So some people, it is important to find out what that mutation is because although there may not be any therapies available right now, we don't know what's coming down the line. And there are lots of people doing lots of great research on all of these different conditions, and sometimes it might just be a matter of time. And if you're someone who wants to be at the front of the line, this might be an important thing for you to know, is what's my genetic mutation? Okay? I'm just trying to make sure I didn't miss any points. And other reasons as well, if you are part of the Foundation Fighting Blindness Patient Registry, there are places within that registry to note what your genetic mutation is. And although your genetic counselor may not be aware of a certain trial that's ongoing, sometimes the FFB is in contact with patients because of your status on your registry of what mutation is known. Okay? So there was a video right at the beginning. It was a little bit of a teaser. So what's gene therapy? I guess that's one of the hot topics in terms of therapies for patients right now. What is genetic therapy? What is gene therapy? What is it doing? How does it work? So it covers a lot of the points I talked about. We know that when someone has an eye disease, their gene isn't working properly. We know that that causes an eye disease. We know that we need to know the specific gene that's causing that eye disease in a person to treat it. So in gene therapy, what the idea is, and the video covered it quite nicely, is the idea is to give the body a working copy of that gene to mask the fact that they have a copy that's not working properly. And by giving the body an instruction that's working properly, the eye will go, aha, now I know what to do, and start to fix itself. Now, these trials are ongoing. They're not available in the clinic at this point, and we're still in the early stages. There are some genetic eye diseases where it's further along in the process, and some where they're not testing humans yet, but they're looking at it in things like mice or dogs and trying to just figure out, does this work? But the general idea is, if we use a virus, which all of the virus and the bad things in the virus are taken out, so we're not injecting flus into people's eyes, but what they're doing is taking out all of those bad virus genes, and what they're doing is putting in genes that work, only that gene that we know isn't working in that person. And that gene will be inserted into the eye, and therefore it'll multiply, because viruses get you sick, because basically what they do is infect your body. They get in there and they multiply and they take over and they give you a runny nose and a headache and a cough and your chest hurts. And for this, we know that the genes that they put in, the viruses are in your eye, and they're meant to stay in your eye, because that's where those genes are doing their job. And so by working in the eye and by telling the eye and multiplying in the eye only, the hope is that it tells the eye, this is now how to work, and fix those areas. Now, it's not a perfect therapy. It's not a cure. It's not something that as soon as you get this, and if you have, you're only seeing shadows, you're not suddenly going to see the same thing that someone with 20/20 vision is going to see. But it does improve functionality for a lot of individuals. And it may increase the visual acuity in a little bit. It may allow you to see color if you haven't seen color in a while. So it's not a perfect fix. It doesn't improve vision 100%. But it does improve the vision that you have for some people, and for others it does stabilize vision if it's currently declining, which is still an important thing, is to maintain the vision that you do have. So this is kind of the process of where these therapies work. We're still learning more and more how well they work. Do they work better in young children? Do they work better in older adults? Those are questions we're learning right now as studies go on. What we're finding is that perhaps the younger that you are, maybe the better it will work, because it's preserving the function that your eyes currently have. And the more damage that has been done to your eye over time, it's harder to fix and restore what has been damaged, whereas in a younger child, it may be easier to fix what is still working properly, which may be more in a 5-year-old than in a 50-year-old. However, we're still tweaking I'm not tweaking these processes. There are researchers out there who are doing this research and who are trying to find ways to improve these techniques all the time. How can we make it work best for the most amount of people? And so that's really something I know that's the hot topic, and a lot of people ask, well, when's gene therapy going to be available for me? And we know that there are certain eye diseases that are going through these clinical trials right now. Some are in later stages, and some are still in the early phases. And some are, like I said, only being thought about on a very basic research level, where they're thinking about, can we do this for this eye disease? We know what the gene is. Does it work? Can we try it in mice? Let's try it in cells first, and then we'll move. So it does seem to take sometimes like a really long time. But the reason that it takes so long is because we want to make sure it's safe before we do this in anyone's eyes. It's really important that we're not injecting viruses that may or may not work and may or may not have had all their virus function removed if we don't actually know and we have a lot of years behind it of research and studying. We want to make sure that we're actually doing something that's going to be helpful for people. Because part of the research as well, we hope that by the time it gets to that stage, it will be helpful for patients and individuals and their families. We don't want to give people false hope for a trial that's not working. So, although it may take a long time, you may have been Googling or looking up your eye disease or clinicaltrials.gov and seeing what's going on for my eye disease. Something may not be there yet. Maybe it'll be 5 years. Maybe it'll be 10 years. But there are people who are working on these things, and knowing some of that genetic information, although that's something maybe your end goal to get you there at that point in time, hopefully having the knowledge about the genetic information in your family and your personal eye disease is empowering to you, because it gives you a little bit of power to learn about what's going on with me. What kind of studies are happening for my specific eye disease? And that in itself gives some people a lot of hope. So I guess I'm going to open it now. We have about 20 minutes for questions. If there are anything afterwards that you're not comfortable asking to the group as well, I welcome you to find myself later. And I'm going to invite my colleague, Nolan, up to the front as well to help. And then if anyone who lives in the London area is interested in coming in for a genetic counseling session, it's likely that if you come to the London Health Sciences Centre and you live in this catchment area, that you will meet with either myself or Nolan, who see individuals with these eye diseases. So I welcome any questions.
My wife and I were genetically tested 10 years ago. Would it be worthwhile being retested again?
So I guess the first thing I would say to that is, did they find what the genetic mutation was? Is it yourself or your wife, or was it a child that's affected? Both you and your wife carry a gene. So do you have an eye disease?
No, my youngest daughter does.
Okay. And did they find out what the genetic mutation was in your daughter or the two of you?
I believe they did.
Okay, so if they have found it, there's likely nothing else to look for. Our genetic information, we're born with it, and it doesn't change over time. So if they did find the genetic cause for the eye disease that runs in your family, that you and your wife are carriers of a specific change, and they found the changes in your daughter, then at this point in time, in terms of genetic testing, you wouldn't need to come back to a genetics clinic for that information. If you do want some more information on is there anything known about the disease, and you can either speak to the ophthalmologist, or you're certainly welcome to come to a genetics clinic to just learn a little bit more about what's been going on in that area if you're interested.
At that point in time, there was no grandkids involved.
Right.
Should we bring grandkids in at this point?
So that's something to think about as well. So the implications for family disease. Do you have more than just one daughter?
Yes.
Okay, so for your other children, I don't know if they were interested, they could find out if they were carriers as well. And then, because if they are not carriers, they can't pass it on to their children. But if they were carriers, they could pass it on. At this point, we don't test usually children under 18 to find out if they're a carrier of genetic eye disease, simply because it's not going to change anything for their health. We usually wait until someone's an adult to make those decisions about their eye health, because we hope they're not having children at a younger age like that, and that when they are 18, they can make that decision on whether it's important or not that they know they're a carrier. But certainly your other children could find out if that's even a concern for their children in the future to have those eye diseases. And for your daughter, I don't know if she's gone on to have children at this point in time or not.
Not yet.
No. So it would be something, depending on which gene it is, I mean, there's different likelihoods that people are carriers in the general population. If she meets someone and she's thinking of having children and it's a concern for her to pass that on, her partner could certainly be seen in a genetics clinic as well, along with her, to find out if he would be a carrier for the same condition, to see if there would be even a chance. it's probably very low that she would have a child with the same eye disease that she has, unless he was a carrier. But if she wanted to rule that out with complete certainty, then that's something that they could come to a genetics clinic for.
Okay, thank you.
You're welcome.
And I'll just add in there that sometimes the understanding of what's actually found within the gene, if it was 10 years ago, sometimes that evolves over time. So revisiting that actual test report and looking at new literature published on that specific mutation might allow us to better predict the natural history of the condition.
Hi, I was wondering what cost is involved
Yeah.
in having the genetic testing?
Okay, so if it's slightly different depending on where you're from. If you're from Ontario, if you're an individual who lives in Ontario, the cost of coming to see a genetic counselor, it's covered within the OHIP program, and through the genetic testing, as long as it's clinically indicated, like there's a family history of the disease, then certainly it's covered by OHIP.
Okay. Now, years ago when I was going to have children, I saw a genetic physician, counselor. I don't know what they considered it at the time.
Yeah.
Would those records be accessible to you?
So
type
the
thing?
process, if you're being seen in a center that's different from many, many years ago, there are ways for us to access genetic information from different sites and centers. We often get patients to sign what we call a release of information. Records before the 70s are really hard to get from some hospitals, sometimes before the 80s, but if most of the time genetic testing has been done before that time, and if it has, we usually can, with that person's permission, is access their records from wherever it was they were seen and have them faxed over to where you would be seen now.
Okay. So is it a doctor's referral to see you?
So yes, so if you want to come see someone in genetics, what you need to do is ask your family doctor or your ophthalmologist or your family member's ophthalmologist to make a referral to your local genetics clinic.
Okay.
Most of the time, if you have a known diagnosis in the family and you're coming to learn about the genetic disease, it's a referral to see a genetic counselor.
Okay. So if I was to have genetic testing, would any of my affected children need to have the testing as well, or would it kind of be a blanket coverage?
That's a good question. So have the children had any testing in the past?
Just eye testing,
Yeah,
like a
okay.
confirmed diagnosis,
Okay.
but no genetic.
Okay. So we often start with an individual who has been diagnosed with the disease. We know that genetic tests aren't perfect, and they can't find 100% of all the genetic changes that happen. The most likely that we are to find a genetic mutation is in someone who has the disease themselves. Because if we started with you, we don't necessarily know what we're looking for. And if we don't find anything, we don't know if that's because the technology didn't work or there's another reason because of that. It's a missed sample. But if we're starting with someone who has the disease themselves, we should know exactly what we're looking for is two mutations. The test may not be perfect and may not find the mutations, but once we've found something in an affected family member, then we know what to test the parents for. We know what to test the siblings. And that. Did you have a point to add?
Yeah, I'll just talk a little bit about cost, because you did mention one thing about the cost of an appointment and actually the cost of testing. So typically testing is covered by OHIP within Ontario, and it's not a cost that's incurred by the patient.
Can I ask one last question?
Yes.
Okay, so if I have the disease and I want the genetic testing, does my spouse as well need to come?
That would be completely up to you if you want them to come to listen to the information. Anyone can come with you to a genetics appointment to learn the information.
But he wouldn't need testing if I'm known to have the disease.
So if you're someone who has the disease,
Yes.
and we're testing you for your genetic mutations,
Correct.
there's, I guess, the use of your partner being there might be a second set of ears to hear the information to take home and remember, but we wouldn't necessarily be testing that person at that specific appointment for anything.
Okay, thank you.
If they did want testing, think about further down the road type thing.
Hi. 2 questions, and I'll keep it to that. Oh, well, actually, the first is just a point of interest that my gene was identified, and it was identified because I bugged the hell out of my genetic counselor to go back and retest the gene once newer genes had been discovered, and it was only then that my gene was identified. So that's
Yes.
that's the first point. And the first question really is: once a gene has been identified, how was a decision made amongst researchers to run trials?
Okay. So I'm going to make two comments. So first, in that the comment you made in terms of finding, they didn't find something the first time, but a few years later, you go back and they were able to find the gene. So that's something. If you have seen genetics in the past, our knowledge is always changing. There's a lot of research ongoing. It's hard for genetics clinics to go back and contact everyone that they see to say, oh, there's something new we found, we should test you for that. So we always encourage patients and families to contact the clinic again to say, is there anything new that's ongoing? Is there any new information that you have? Because I really am motivated to know what that genetic change is. So I think it's a great thing that you were contacting the clinic to say, what's going on for me? Because our information changes and it's so hard to keep up with all of those patients. In terms of your question regarding how do researchers decide when to start testing, usually the first genes that they start to do these trials in are A, the genes that have been known for a long time, but B, genes that are, when we think about the genetic eye disease, the genes that are most commonly causing the disease. And then we kind of work there out. So for example, for Leber's congenital amaurosis, they have clinical trials for a gene called RPE65. One of the reasons is they've known about that gene for a long time, so they've been able to study it for a long time. The second reason is because it accounts for a significant proportion of known mutations for patients with LCA. So when you think about it, there's at least 10 different genes that are involved in causing this. And for LCA, RPE65 I don't have the number off the top of my head. I know it accounts for more than, I think, 15% of the cases, where some of them, if it's a newly identified gene, we've only tested a few patients, maybe it only accounts for 1%. So what they try to do is target the gene that's affecting the most people that we know about in the population, because that's where the major therapeutic effect is going to take place in the patients that have the most common gene.
I'm wondering if you could possibly tell me how long the process takes from the time you've applied to the clinic to actually have some testing and then to meet with a
genetic counselor?
Yes.
It does depend on where you're living and the wait list for the specific clinic. If you live in the London catchment area, it's probably about a 2-month wait list. So by the time your doctor refers you, that we make sure it's an appropriate referral and we have all the documents we need before we see you, and the time we book an appointment, it's usually a 2-month wait list in the London area. It depends on different centers. For example, there are genetic counselors in Toronto that work at an ophthalmology clinic there. Some of you may be familiar with them. There's Megan Day and Joanne Sutherland. And their wait list is a bit longer because in Toronto it's a specialty clinic and they often have a physician involved. So when you go, you often see an eye doctor and then you meet with the counselors after. And that's a bit of a longer wait list because they are a busy center that specializes only in eye diseases. So if you want to be seen at that center, the wait list is a bit longer. Different clinics may have longer or shorter wait lists. We do have one of the shorter wait lists in this area of southwestern Ontario.
So if I've made application, and I have done that, but it was at least 6 months ago, so I should recall. Should I phone again and just
if you have asked if your doctor has sent in a referral or
yes.
Certainly follow up.
Okay.
You can always ask the doctor to send the fax again or ask what the status of that referral is.
All right.
Because if it's been 6 months, that's been quite a bit of time.
Okay,
We are
thank
a
you.
specialty clinic, and that's the other hard thing, that genetics are specialty clinics, and I'm sure everyone who has these rare eye diseases know that sometimes it takes a long time to see a specialist in the area, but 6 months for a genetics clinic is a bit of time.
Well, I should
Or
clarify,
Thank
for
you.
the pediatric appointments, the wait list is up to a year.
if it's a child. If it's for a child assessment, but if it's not, no.
I was wondering, I went for genetic testing about 5 years ago, and they weren't really able to identify any of the genes that had mutations. They did mention that it could have actually started with me, so it was a mutation that wasn't passed on by, it wasn't passed on by my parents, but just mutated in my own body.
Yeah.
So I was just wondering, should if they haven't been able to identify any of the genes, should my son be tested? Should my parents be tested? Or is there any value in that?
Right. So as we were mentioning earlier, it's always best to start with the person who themselves has the eye disease. So if that is yourself, then we would say, if it's been a number of years since you've been tested, it doesn't hurt to call the clinic that you were seen in and first say, have there been any new changes? Or what are the changes in the technology? Because sometimes the tests only can find 40% of mutations, where now maybe they're able to find 60% or 70%. Or maybe they have 6 new genes that are known, and that might be what's responsible. So first, to start with that person. At this point in time, going on to test your son or your parents wouldn't be helpful because we don't know that inheritance pattern. If you were estimated to be maybe a new person in your family, which does happen, sometimes randomly genetics makes mistakes, and in someone they're the first person in their family, it's hard to know exactly how is that inherited, and we don't know if we find anything in your parents or your son. So it'd always be best to start with you first.
Okay. And is it more likely that the mutation started with you if your eye disease is not typical? Sorry, the symptoms. So I've been diagnosed with RP, but my symptoms don't look like a lot of other people with RP. So could I be misdiagnosed, or is it more likely that the mutation started with me, so it's kind of new or different than others?
I think that's really hard to say. I mean, it may be the case that it's a gene that we don't know about, and therefore we don't know how to classify that type of RP. We haven't identified it before. And sometimes the specific genetic mutation, that spelling mistake that happened in a person, give unique features. We know that some people, have RP, but everyone with RP has a slightly different type of RP. They all have the same similar features, but their age at which they were diagnosed can be different. When they're losing their night vision versus when they start to lose their visual acuity and their peripheral vision, it all changes, and sometimes that's based on the gene or the specific mutation. So it's really hard to say exactly what the reason might be for those atypical features. I mean, we always say there's always room for error in clinical diagnosis, and the genetic testing helps to confirm that clinical diagnosis, but I wouldn't be able to say, just based on what you described, if it's a misdiagnosis or if it's just an atypical form of the disease based on an interesting gene mutation.
Okay, and just one other quick question. If the mutation started with you, is there any idea of what the chances of your children inheriting that, like the recessive, and that we know how that is inherited? But is there any, if you could explain that?
Yep. Most of the time, now there's always exceptions in genetics, but most of the time when someone is the first person diagnosed in their family, when they go on to have children, it's often passed on in an autosomal dominant manner. So where it's a 50% chance for the child. But like I said, there's exceptions to every rule, and it's hard to make any predictions about that.
Mine's a quick question. It's actually building on what this lady over here was saying. I know Dr. Hayon was working on a common database and patient registry. So if somebody comes into you and gets their testing done, what happens with that information? Is it going into a common database now, or do you have a separate database from what Sick Kids in Toronto has?
So we don't have our own database. We're not as specialized a center as what Dr. Hayon does have in Toronto. But certainly if patients do want our information to go that way, we've trained with, Nolan and I trained with Joanne and Megan and Dr. Hayon, so we're very familiar. And if a patient did say, we want our information to go that way, knowing that they have that, we can always certainly arrange and with patient consent forward that information on if they want that, if you want that housed at their database there.
On our website, on the FFB website, you can go to the patient registry, and the forms are there that you can take to your ophthalmologist or your genetic counselor, and they will forward those on to Sick Kids for the Foundation Fighting Blindness Patient Registry. Okay. So I'd like to thank you and Nolan for sharing your expertise with us today, and I'd like to thank everybody in our audience for their questions. Yes.